So our textbooks, I guess I have to kind of do that. You won't need to read the additional text, but Current is where I get all my stuff from. I referenced all the 2026 chapters. Really, it's only if you're like, I don't know what she's saying, I can't quite get this concept, come talk to me. If you don't want to do that, you can read the text. This Goldman Cecil, goods in your weeds, and the font is really small. But again, if you just want to know a little bit more, you can go to that. But you shouldn't need to. All right, so endocrinology is all about hormones, right? And there's this quest for homeostasis. What's homeostasis? Yeah, it's like this perfect balance, right? And so when we talk about endo, I always start with what normal looks like. And I promise if you can get normal and those normal feedback loops, when it comes to a test, and even sometimes when it comes to which lab and treatment, if you go back to normal, it can help you, so that you're not as confused. But again, yeah, it's the never-ending quest for homeostasis, right? And I know in like your anatomy and phys, you probably focused more on the normal feedback loops, and in this one we're going to go into the diseases, what that looks like clinically, the labs order, and the treatment, because as PAs, we are treating them, right? This is what the course looks like. So just, to be honest, the first test is harder. It's because these concepts are harder. I mean, obesity is kind of hard to like mix up, right? Diabetes, you guys have heard a lot about diabetes already, but that's why this first block is a little bit harder. If you guys just get stuff confused sometimes, but you won't. You're gonna figure it out. Like I said, the last, everyone's done relatively well, but it is hard. It's very ology heavy, medicine heavy. But I do a review and we do some cases to help solidify the topics. By now, you guys probably have the way that you study down, right? This is your junior semester. Some of you will be those people who are just like, you just took cards. What's Friday? Farm. So right now, all you're thinking about is farm, and that's fine. You can, I hope you pay attention, but you can do whatever works for you. But I promise, if you wait till the end to get any exposure to endo, it'll be overwhelming. So I encourage you to pay attention, because I do hit home some stuff. But again, it's your choice. All right. So when it comes to endocrinology, remember the CORC case we had? And they had a very classic presentation, right? Right. What was this? Like hypertension, right? The different pulses, the age, all of that. That's how endo is. We'll have these very classic cluster of physical exam findings, cluster of signs and symptoms that get you to the diagnosis, right? So some people really like that. It's like a puzzle you have to solve, and others are like, no, I like ortho, tell me where it hurts, good, I'm good to go, right? So there's a kind of like a mystery you have to solve. But we'll learn that. The hardest thing, I think, for you guys will be the labs and imaging, so hopefully by then you'll feel more confident with that, and then what to treat with. Okay? So I will not give you any subclinical cases. What's a subclinical case?
Almost means the diagnosis.
Yeah, and that is what you will see in real life. Subclinical, especially hypogonadism, so testosterone. A lot of subclinical hypothyroidism, but I won't do that. I will do if it's hypo, it'll be very clear that it's hypo. But sometimes I add a little bit of clinical nuances just so you realize that it's not. You don't always present this picture perfect way, but they will on the test. Okay. I give you labs and all of that, normal lab ranges, except for one topic, which we'll get into, and that's next block, so you'll know. And then obviously know your medical terminology. Why are we learning about certain topics? Pants, right, ultimately. We're all held to the same crediting requirement, so it was 7%, now it's 6%. But they increased the topics, they decreased the percentage, but increased the topics, so this just ties all the topics to the lectures. And obesity is technically under gastroenterology, but it makes sense with diabetes. And I like talking about it, so it works out well. All right, ready to do a test question? All right, we have a 32-year-old male presents to primary care complaining of weight gain. He's gained 40 pounds in the last year. His medical history and physical exam indicate an underlying endocrine disorder. Which of the following hormone is secreted by the adrenal cortex? So this is a first order question, right? And typically all I would do is just ask the green, but because the PANCE doesn't do that, I add a little bit of the extra buffer. So again, just remember, I do put first order questions in there, but this stuff before is trying to help get you to the right answer. All right, what do you think? Cortisol? Oh gosh, good job. All right, the same guy, but we have a little bit more. We're turning this into a second order question. 32-year-old, 40-pound weight gain. He also reports symmetrical joint pain, increasing fatigue. Everyone in ENDO is tired. Everybody's tired. So okay. His boot size has changed by 2 sizes during this period. We do a physical exam, right? You get a good history, go to the physical exam. His blood pressure is 152/98. What do you think? Are we okay with that? It's high, right? Potentially. His BMI is 38. You'll learn that is definitely obesity. It's class 2. And his weight increase is confirmed. So you reviewed vitals, and for sure you confirmed 40-pound weight gain in a year. Is that a lot? Yeah, that's a lot. That stands out, right? Now somebody could challenge accepted, because someone out there could probably gain 40 pounds in a year if they were challenged, right? But yeah, that stands out to me. We keep doing the physical exam, and you notice an enlarged forehead, palmar hyperhidrosis. What's hyperhidrosis? Yeah, super sweaty hand. And proganthus. This isn't the jaw protrusion, so his jaw is protruding out. So we have these, do you see there's this classic physical exam, cluster of physical exam stuff pointing to one thing? What do you think this guy has? What's he most likely diagnosed? Yeah, C, perfect. So we can take the same question and turn it into a third order question. So the story is all the same, but which of the following is the best initial laboratory test for this suspected condition? Now we haven't taught this yet, so this is probably the hardest one. What do you guys think? I hear B. Okay. I hear E. Awesome. Yeah, it's E, and we'll get to why. You'll learn. But B and E are what I usually get more B's than E with this question. So we will learn that too. All right. Again, this just is like a nice pretty table that summarizes that people come in with, if I just give you a question and I say this 32-year-old had fatigue, can you get to the diagnosis? No, I have to give you more, and again, I'm going to keep it to those classic things. But understand, somebody doesn't come in and say, I think I have hypopituitarism, right? No, they come in with weight loss, abnormal vitals, loss of axillary hair, and things like that. So you still have to problem solve. Don't just like memorize the tables. And then these are how physical exam, your classic physical exam findings will also correlate to your condition. We don't have to cover Turner syndrome or primary ovarian failure, but you're going to get that in another class. So user in ClinCore, you haven't really, we have like had one lab, maybe some of you haven't had a lab yet, but when I tell my ClinCore group, I like ClinCore because it's very much like phase 2, like I don't have to teach with the PowerPoint. But a good history and a good physical exam point to the right direction in ClinCore. Same with ENDO, it's a good history physical exam. Obviously, you listen to the patient in ClinCore, but what we add on in here is the medical knowledge, labs, lots of labs, RADs, and imaging, okay? So we have overlap with our other classes, which is kind of cool. Doesn't always happen. All right, so here's the objectives of this section. Because you can see how many slides? I don't know, mine says 46. You guys probably have like 30 something. Yeah, it's really short. But we need to go define some terms because I'm going to be using these terms a lot. So what do hormones regulate?
Everything.
We like, obviously weight, because that guy had a lot of weight gain. What else? Development, reproduction, growth. Today we're going to talk about how it deals with water and electrolytes. And then energy and stress, and stress response. Poor cortisol, it gets a bad rap, but we need it. So we'll talk about all of that. But essentially hormones are responsible for a lot of things in the body. Okay. So this slide makes more sense when you've had, usually you guys have already had neuro. If you remember back, essentially there's overlap between endocrinology and how it works with how the nervous system works. And the nervous system is fast, right? We have neurotransmitters, they're fired in a synapse, and you get a fast reaction. Endo is a little bit different. Instead of neurotransmitters, it's hormones. Instead of in a close synapse, it's usually from the pituitary gland to some organ farther away, and it travels through the bloodstream. And the effects take a while, right? It's not, sometimes it's instantaneous, but most of the time it takes a while, and it takes a while to get back to that homeostasis. when we look at our hormones in the blood, you have free and bound hormones. This is not like a test question, it's just remember the stuff from Clin Lab, and then you'll see a lot of the labs will be like free T4, and this is why, so they need to be bound to something to travel through the bloodstream before they get to that active form, which is the free form. Okay? So essentially, they travel through the bloodstream with their buddy, they get to the cell, and then they become that active form where they can do what they need to do. So this is just kind of a review again from patho probably, but hormones, most of them are these large lipid insoluble hormones where they can travel through the bloodstream just fine, but they can't get into the cell without a receptor. And once they bind to that receptor, it triggers a cascade of events, and that target cell does what it needs. There are still thyroids, which are your thyroid hormones, and your steroids. Those are lipid soluble though, and so they can go, although they can go directly into the cell and do what they need to do, they need to be chaperoned. Okay? You don't have to memorize the list at the bottom, but I mean it's kind of intuitive if you see steroid and thyroids are just steroids and thyroids, and then everything else is your polypeptide. Okay? Again, not necessarily you have to memorize, but just recap. This next slide is something you need to understand. Negative feedback system. Okay, I have a picture. I like the pictures better. But again, when levels of a hormone are high, that decreases synthesis and secretion. Right? When those levels are low, we're going to increase synthesis. Okay, and so the best way is picture. So we have homeostasis. Something is messed up, and homeostasis is disrupted. So we don't have enough T4 and T3. So thyroid hormone is low. So that triggers the hypothalamus and the pituitary to do what? Increase synthesis and secretion. How it does that is by releasing a hormone into the bloodstream to go to the target gland and to the thyroid. So TSH, thyroid stimulating hormone, says thyroid, do what I need you to do. I need you to produce more T4 and T3. Thyroid gland says yes, sir, yes, ma'am. I'm going to release T4 and T3 in the bloodstream, and we get homeostasis. Okay. We will go through these feedback loops at the beginning of each topic. So again, you can rely on what normal looks like if you get tripped up in the test. This is a nice review, yeah? Bring it back. All right, so positive feedback system is the opposite. We don't talk about that in ENDO. You'll talk about it in women's health, but just know it's the opposite. You can, but not for my test. I won't have any positive feedback, okay? It's FYI. Oxytocin is your example. So we have the negative feedback loop, but it's just understand this with receptor regulation, just so it's not negative feedback alone, right? There's these receptors on cell that kind of also help maintain homeostasis. So if we have excess hormone, we have too much thyroid hormone in the body, then the receptors are going to decrease availability to help decrease that target response, and vice versa. When there's not enough hormone in the body, we need more, then that receptor availability will kick up. Okay? That's not just one thing. All right, this is an important topic. It's very simple, but I talk about it all the time. And so if you get tripped up, you'll get tripped up on the exam. Okay, so we're talking about alteration, so not homeostasis. Something is going on wrong in the body. We have an endocrine disorder that's causing hyperfunction. Okay, so we have primary hyperfunction, and it tells me that's an alteration of the gland itself. So if I say you have a thyroid hyperfunction, where's the problem? Thyroid, yeah. Okay, and then secondary means the alteration, the problem is up here in pituitary or hypothalamus. So if I say you have a secondary hyperfunction, where is that? Pituitary, right? Okay. Simple, but people get mixed up on it. And then ectopic. This one is probably pretty self-explanatory from the pathology days, but again, there's an excess hormone being secreted outside of the endocrine loop, right? There's some ectopic, usually a tumor cell that's producing out extra hormone that it shouldn't be. Okay. Switch gears to hypofunction. So if I say I have a primary adrenal insufficiency, where's the problem? Pituitary or the adrenals? Adrenals, primary, it's the actual organ. Now if I say this patient has a secondary adrenal insufficiency, so insufficiency is including me that it's hypofunction, secondary is telling me where's the problem? In the pituitary, right? And then resistance is interesting. So resistance it happens when, again, the feedback loop is working great, but when it gets to the target cells, it's resistant. So all the hormones where it needs to be, but it can't do its job at the actual, typically at the target cell. And we'll talk about that with the kidneys today. So resistance. So ultimately, as you learn through each condition, a lot of this will help, you'll understand this for diagnosis, but it also helps you with labs. And this is our last slide of terminology. Adenoma. I'm going to say adenoma over and over and over again tomorrow. But it's benign enlargement of a cluster of glandular cells. They can be secreting or non-secreting. Okay, so we'll talk about pituitary adenomas, adrenal adenomas, a lot while we're here. They can be malignant, but typically they're benign. Okay, so I'm going to go with the typical most of the time. I'm not going to try to trip you up. Neoplasm, on the other hand, is what? Okay, it's a new growth of tissue, usually malignant. Hyperplasia, benign enlargement of the entire gland. So I might say, if I ask you like what's thyroid hyperplasia or adrenal hyperplasia, do you think those organs, if they're in this hyperplasia state, they're going to work normal? No. They can, with the thyroid, it might produce excess hormone. With the adrenals, it can actually do either one. It can produce excess cortisol, or it gets bigger and it starts to fail, and then you get insufficient cortisol. So again, you see how that's different than adenoma. And then atrophy, pretty straightforward, right? Wasting away the cells. When it's a congenital issue, you'll have hypoplasia where something didn't grow as it was supposed to in utero. So we have a few cases of that, but not many. Mostly, like lots of adenoma, lots of hyperplasia, and then neoplasm is enhancement. So that's it for terms. Pretty short and sweet. We're going to go into the second. Any questions? All right. Didn't notice on Friday, I do talk fast, and I'm sorry. Mr. Weber, did you have Mr. Weber? Okay, so when I told him, he's been teaching forever, I was like, Mr. Weber, I have to talk slower. And I was like, don't do it, because then it won't be you. So, but again, I will, if you need me to talk slower, I will. Usually you guys like it, because then I move faster. Your day goes by faster. But if you come see me and be like, just a little bit, slow down a little, and I will do my best. All right, so posterior pituitary. This is lesson 2. I think you're gonna like because there's only 2 conditions and 1 hormone, so that's rare, as you'll see moving forward. So before we talk about the conditions and the hormone, let's go back to anatomy, a review of anatomy regarding the pituitary. So where is that guy at? Pituitary. All things endo start kind of here. You have your hypothalamus, which is above, and then this little tiny pea-shaped pituitary gland in the sella turcica, nice and protected. There's not a lot of space, and we'll get to that tomorrow when there's not a lot of space, maybe from like an adenoma growing on the pituitary can cause some problems, right? So specifically the posterior pituitary, where's more of the action happening? Anterior or posterior? Yeah, anterior all day. The posterior is actually not a gland. You'll see in a couple slides that it's actually just stores hormones, and it's an extension of the nerves from the hypothalamus. So let's take a little bit closer. So again, you have the right side anterior pituitary, that's coming. But again, you have it's neurosecretory cells, so it's not an actual true gland. So ADH is the hormone we're going to talk about. ADH is created in the hypothalamus and it's stored in the posterior pituitary. And when it's triggered to be released, it goes through the blood cells to the target organ. It's control with ADH it's a really tight specification. So I always think that we need ADH ready to go for when our body needs it. Now, oxytocin is another hormone that is secreted by the posterior pituitary, but we're not going to talk about that. You'll get that in women's health. So, not bad, right? 1 hormone, 2 disorders. Sometimes the posterior pituitary gland in textbooks, you might see it called the neurohypophysis, and that's again correlated to the fact that it's not a true gland, but it's the distal axonal neurons from the hypothalamus. That's it for anatomy. So let's go through normal function and talk a little bit more about ADH. So ADH, does anyone remember what that is? Yeah, antidiuretic hormone. It's in the name. It tells me how cool is that? It tells me exactly what does it do. Antidiuretic. Stops you pee. It's the anti-pee hormone. So if there's a release of if you have a hormone that stops you peeing, it's also it's doing that through retaining water. So it increases water into the body. What will happen to my urine if ADH is released? Yeah, it's really concentrated. I'm going to pee less, right? So that's a key factor when we decide, what kind of conditions currently you're trying to get me to remember. Another name, obviously antidiuretic, is I usually just try to be consistent with ADH. I don't usually call it the anti-pee hormone. If you like that works. But arginine vasopressin, you'll see that a lot in the textbooks. What does that name, vasopressin, what does it tell you this does? Yeah, it's a pressor, right? It's a weak pressor. But it does work. So your body you have to lose a lot of fluid, a lot of volume for this to be released. What kind of condition would you need where you have like low fluids? You need a pressor.
Trauma.
Yeah, like trauma, a lot of blood loss, shock, right? So again, and it's triggered by the V1 receptors that trigger ADH to be a pressor. What I care about in ENDO is your V2 receptors. So we're going to go into the nephron. Anybody like nephron? I sucked at memorizing these in school. But again, we're going to keep it real simple. But again, the V2 receptors on the collecting duct of the kidneys. Again, because we're dealing with water retention. And you'll understand these 2 points as we go, at the bottom as we go. Okay. So let's look at that nephron. Who is excited? Yeah. So again, we're talking about the collecting duct, the distal collecting duct. So when ADH is released from the posterior pituitary, it goes through the bloodstream down to the kidneys, specifically the distal collecting duct. And when it goes up, it increases aquaphorins. And aquaphorins are really just channels that do what? They're going to pull that water into the body, right? We need more water into the body, so as I pull that in, urine decreases, okay? And that's essentially a really simplistic view of how this works, okay? Ultimately, increasing the serum or the body water content and decreasing the urine output. So what stimulates ADH release? So we'll just go straight to the bottom real quick. Situational awareness, the baroreceptors, right? That has to do with the pressors in the vessels. So cool. That's not what I care about. What I care about is the osmoreceptors. So again, the hypothalamus is told through these osmoreceptors that serum osmolality is off, right? So there's a change in serum osmolality, and it likes to keep it really, really tight control. So if there's a change by 1 to 2%, which is insane, 1 to 2% increase in your serum osmolality, ADH is released. Okay? So what is serum osmolality? Let me just think, just like simplistic view is just essentially think of it as like the serum concentration of sodium is kind of what I prioritize. But it's not just sodium, it's glucose, it's BUN. There's this really fun math problem you can do. Don't need to do on a test, but again, so it's kind of the serum, the concentration of sodium and some other things, all right? So when serum osmolality is high, what does that tell me? What is it? Is it super concentrated, right? Does that make sense why we need ADH? Because ADH pulls the water in, and so it gets to that kind of homeostasis, okay? So hopefully that makes sense. When serum osmolality goes up, it's nice and concentrated. ADH what? Up or down? Up, right? We need it to maintain homeostasis. This is just kind of a summary of what I just said, right? Hyperosmolar state, concentrated serum will stimulate ADH. Obviously, when we lose a lot of blood, when we're in a shock state, we're going to get ADH. And then medications, damn medications, like to stimulate and inhibit all sorts of things. And then on the opposite side, Because the hypoosmolality will decrease ADH release. Alcohol. Why is alcohol unique? How would alcohol inhibit it?
It's a diuretic.
Yeah, it's a diuretic, right? So it inhibits the release of ADH. It makes you pee. How is that? That could be a problem, right? So if I'm watching the game, I'm drinking a lot of beer, I'm peeing out, I'm blocking my ADH, I could get dehydrated, right? Here's your pretty little table. Again, it kind of ties the blood vessel and the kidney response together, but I just care more about the osmoreceptors and the retaining of water, decreasing urine output. How do you guys feel? Okay? Yeah, just don't overthink it and it'll be good. And if you're like, I'm trying not to overthink it, but I still know what's going on, let me know. And we can help you out with it. All right. Is we'll go through, I think maybe we can get through one disorder and we'll have a break. So the first disorder is SIADH, what we're going to talk about. So we have SIADH, syndrome of inappropriate ADH hormone, and something called diabetes insipidus. Okay. Luckily, they're exact opposites. So they're going to. How do you think they'll present? Opposite in some ways, right? So we're going to use our knowledge of what you just reviewed, what happens with ADH normally, to help you out with this. So below is just like, kind of when you think of ADH, you're going to always ask about urine, right? Are they peeing more or less? Is their thirst intact? That's really important, especially when they're peeing a lot. And then we got to look at the labs. Not just the urine, but we need to look at the serum. Okay, so we'll learn all of that today. So, what's your guess? Is ADH high or low in case someone with SIADH? It's high, right? It's in the name. I love this. So I love when it's in the name and I don't have to think of use extra brain cells, but it's inappropriate release of ADH. So we know that there's the hypothalamus is triggered to release ADH based on serum osmolality. That's not the case here. The initial problem, there was no stimulus. Something is causing inappropriate ADH to be released. They're not invited to the party. They're coming anyway, and they're causing this excessive secretion. Okay, in a state where we do not need ADH. So there's a lot of etiologies, and so I try to group them together, and I won't trick you. Okay, so again, let's go through the etiologies that can cause this inappropriate ADH secretion. So the first two, CNS disorders. So something I kind of oversimplify it, and something is going on in the brain where the hypothalamus is, and just screwing stuff up. And so excess ADH is being released when it shouldn't be. Pulmonary diseases, we don't actually understand why this happens. But when someone has a bad pneumonia, or there's bacterial or viral, that can cause excess ADH to be released. And again, we don't really understand. But typically, maybe once that viral infection or that bacterial infection is treated, the SIADH should occur. Malignancies. Malignancies are known to cause excess hormones. So this would be an example of an ectopic source, right? So you have some malignancy or tumor somewhere in the body that is triggering excess ADH. 80% of the time, the trigger is lung cancer. So do you think I should make you memorize all of these cancers, or should I focus on the 80%? So small cell lung cancer, patients commonly have signs and symptoms of excess ADH. So if you have a patient who's coming in and maybe you find SIADH incidentally on labs, or through your great review of systems, you realize that they have really concentrated urine, or maybe you do a EUA for some reason, and you ask them, are you typically somebody who has signs and symptoms of excess ADH, but they have either they're currently smoking or they have a really long history of smoking, and maybe they recently quit. So as thinking SIADH and a tobacco or a smoker, they automatically buy a chest CT and you might find a lung cancer. Okay. And And then we skip down to other causes. The main one on this is post-op. So you have someone who has surgery, you can have post-op SIADH often, especially imagine if we're doing some kind of pituitary surgery, right? And I already told you CNS disorders, messing with the CNS can cause it, and then surgery, so that could trigger SIADH, okay? Usually it's temporary, but those are kind of the main causes of etiology. And then of course, farm comes back to get you guys, right? But you're still in farm, so you get to enjoy that class. For how many more? Where are we at farm?
Test 2.
Two down.
No, test 2 on Friday.
Oh, that's okay. One down. All right, you guys know how to do it by now, right? Okay, so I'm gonna briefly go through these meds, and then I'll kind of tell you how you don't really have to memorize the slide per se. Okay, so antidepressants, specifically in older patients, so over 65, that can increase your ADH. Opioids are big. Your anticonvulsants. Those ones can cause issues. Lamictal. What NSAIDs do can increase ADH because they inhibit prostaglandins, so that's has to do with a problem in the kidney. MDMA. Oh gosh, let's see. 3,4-methyl dioxymethamphetamine. What's that? What's MDMA? What's like I guess MDMA is like the common slang term, but yeah, Molly, ecstasy, right? And so what happens with that is, okay, so most of our patients aren't taking MDMA, or maybe not admitting that they're taking it, but it happens, and you will see it maybe in the ER, or maybe a dependent, or somebody will experiment with this. And again, even though it's not common, it's important that, so it stimulates ADH. So it stimulates ADH, so that means I'm holding in fluid, right? I'm peeing less, but it also stimulates my thirst center. So what am I doing? I'm increasing my serum fluidity, and I'm drinking a bunch of water. See how that can be a problem? My sodium is going to drop. So that's why ecstasy can cause hyponatremia. So you do not need to memorize this list. If I'm going to paint a picture of someone with SIADH, maybe I'll be like a lung cancer patient on Lamictal. Or I'll be like a pneumonia patient who is 65 or 66 and is on an SSRI. Does that make sense? So it'll be a piece of the puzzle to get you to SIADH. Just know that when you have someone with SIADH, make sure you check their meds, okay? Am I causing it? Am I causing this problem? Okay. When we look at someone coming in and presenting with SIADH, they're very specific on acute versus chronic, and it's kind of nice when they give you parameters. So acute is less than 48 hours, and chronic is anything after that. You will probably, hopefully, never see acute. It's usually scarier, and they're sick, but both exist. But chronic is more common. So acute is if you're sick, not sick. I guess I talked about it a lot on Friday. This is a sick patient. They are confused. They're disoriented, lethargic. They might be going into a coma. Why? What's the underlying problem? Yeah, increase of water. What happens to my sodium, my serum sodium? It takes, right? Because it's not because the hyponatremia is because of fluid overload, right? And so very confused, sick patient, okay? Acute, less than 24 hours. But what we're mostly going to see is these often asymptomatic. Sometimes their sodium levels are kind of low, but they feel fine. And it's because the body can kind of adapted to it, and they often feel just fine. But every now and then they might have some concentration issues, balance issues, cognitive impairment. So they might feel like they're fine, and then you diagnose them with SIADH, and then you ask a few more questions. They're like, yeah, I've been a little bit foggy, and things like that, and that could be because of the sodium. Now these patients are really vulnerable to exacerbations where they go and they present in an acute neurologic presentation. So I feel fine right now. I know I have SIADH, but it's easy for me to go into that symptomatic case versus someone without SIADH. And all those symptoms are related to the sodium. Okay. So take home, acute versus chronic. Acute, which one's sick? Yeah. Now, chronic can be sick, but most likely it's that super sick acute patient will present in less than 48 hours, and most commonly we're going to see that chronic asymptomatic or mild presenting patient. So now it's time to evaluate this person, right? So something from their, let's say their medical history, we do our review of systems, and we ask them about urine, their urine. And SIADH is their urine output can be increased or decreased. Decreased, right? Because we're keeping, ADH is holding on all of that fluid, anti-P med. What labs should you think we should order? BMP? Yeah, so CMP. So what BMP is going to take my electrolytes, right? What else? Urinalysis, right? A UA is going to help me, and it's going to say, is it concentrated? Is there an infection? Am I spilling glucose? Things like that, right? And there's a few new labs you're going to learn about. So remember, what triggers ADH? Change in what? Serum osmolality, right? So we're going to actually check serum osmolality and urine osmolality to help. So here are your, stay with me on these labs. It'll come together. I hope. All right, so we're going to do our UA, which we're familiar with, CMP, BMP, because we want to check that. Sodium. What do we expect the sodium to be in an SIADH patient? Low, right? Because we have this diluted, right? It's low sodium as a result of excess water, okay? And then we're going to do these other new tests. So, sodium, I give you a patient who has a normal sodium level, it's not SIADH, okay? Would not do that to you. So, low sodium, and we understand why, right? Because of the osmolality and the dilution when ADH is inappropriately secreted. There's this table here. I just added it because some people like to know. The level of the sodium doesn't always equate to how the patient presents, okay? But just know there's, I guess, ranges when we're dealing with low sodium. Plasma serum osmolality, so that's that concentration. Why is that low in SIADH? Why is it low? It's diluted, right? It's diluted. Okay, urine osmolality is high, urine sodium is high, and urine specific gravity is high. Which one of those is on a UA? Specific gravity. And if it's high, what is that telling me the urine looks like? Super dark. And can you see through it, through the cup? No, it is dark. Probably still yellow, but it's dark. There's the sodium in it, and it's super concentrated, right? So that's all those three things do is tell me what? I have concentrated urine with a low sodium and low serum osmolality. I'm thinking SIADH. We don't specifically in this situation order ADH. Instead, we use the urine osmolality to get to the diagnosis. Okay. We'll finish up the labs and then we'll take a break. So here I added this. I don't know if you like. Some people like a slide like this. Others want a nice little table. But again, all of these labs now make sense because you relearned how homeostasis works with ADH, right? It's low sodium, highly concentrated urine. And I feel just fine. They're like, I'm fine. Yeah, I just don't pee that much. Okay. And then you diagnose them with SIADH. Of course, you have to rule out any other condition, but it will be obvious on the test question. This one is just like a current table. I don't love it, but essentially, if you have flowchart person. All right, we can pause there. Unless you guys want me to wrap up SIADH? Okay, we'll just wrap it up. Okay, so we might go a little bit over, so we'll wrap it up. Okay, so signs and symptoms treatment of SIADH are, again, noting that the problem isn't that they're depleted in sodium, they're sodium's low because of this excess water. So we need to treat the underlying causes. What are the common underlying causes, right? Well, CNS issue, maybe a weird pneumonia, or we don't understand why, but some lung infection is causing it. Maybe they just had surgery. We're going to look at their meds, and then we're going to see, is this maybe a malignancy? Where would the malignancy most likely be? The lungs, right? That small cell lung cancer. Okay, so we're thinking underlying cause for our patient, and then we have to differentiate. This is acute. We differentiate between acuity, is it less than 48 hours or over, and then the severity of the symptoms. Okay. So acute is fairly, again, it's not super common, but I'm only teaching it to you in that severe sick patient zone. So remember, this person is like on the verge of loss of consciousness. They're disoriented. They're confused. You check their serum sodium. It is low. They haven't been peeing. All of these things. And it's less than 48 hours. We're going to give them, we're going to fix it, and we have to fix it soon. So we're going to give them hypertonic saline, 3%. So not lactic bringers, not normal saline, right? We need to give this person the hypertonic saline to treat the hyponatremia, okay? And we got to do it at the rate at which it fell, which is weird, because usually we're really cautious when we replenish sodium. But for these, in that less than 48 hours, super sick patient, we need to treat it at the rate it fell, okay? So again, super sick patient, give them some sodium, kind of quickly. Versus your chronic. So if I have somebody with a chronic, they're going to present one of two ways. They're going to present just fine. Like, I feel fine. You caught this incidentally on my labs. Or they're going to have these neurologic symptoms. And we treat based on that, right? So if they feel just fine, maybe we restrict fluids and we can discuss medications, which will be on the other side. But if they are been having these symptoms, maybe they started out as this asymptomatic SIADH patient, and we're evaluating them. Maybe they have lung cancer or something like that, right? But then they switch to this more severe presentation where they have neurologic symptoms. Then we need to be more aggressive, and we need to give them hypertonic saline, okay? But slow. Remember, the body has gotten used to this low sodium rate, so we can't just throw a bunch of sodium at them ever. We need to, in this case, we need to do it really slow. Because we want to prevent osmotic demyelination syndrome or locked-in syndrome. Have you guys heard of that? There's like a movie of a guy, but essentially, if you replace sodium too fast, you like 2 to 6 days later, they lose function of a lot of things. They're inside, they're fine. They can't function, they're locked in syndrome. So we want to prevent that. So it's nice and slow. For whatever reason, in these acute patients, their risk of locked-in syndrome is much less. But it's super rare that you'll see that, okay? So, correct slowly. Back to this asymptomatic chronic mild patient. Like I said, we can just fluid restrict. At the same time, we're treating the underlying cause. Maybe we're treating that pneumonia. We're adjusting their medications. It's super cool that you can treat something with no meds, right? Like, how cool is that? However, I would not be compliant. I like my fluids. So fluid restriction can be hard for a lot of people. So there's also medication management that you can give these patients. Okay, and then education. We want to watch them so they don't go into an exacerbation where they would need what? What do we treat someone who's chronic? Hypertonic saline slowly. Perfect. And then that's just this again. Hypertonic saline slowly. We're going to monitor them, and then maybe after we get them stable and their symptoms, they're no longer symptomatic, their sodium's at a good spot, then we can obviously treat the underlying condition and we can consider some medications. Do you guys remember vasopressin receptor antagonists, or Vactins from Farm? I've never prescribed them, but they exist. And then honestly, it just does exactly what it does. So this is the medication options. Once they're stable, you can give them a Vactin. And it does exactly what it says. It inhibits V2 receptors. So you're able to pee, right? We're able to stop that ADH impact on the body. There's some Vactins are specific straight to V2 receptors, which are cool. The tolivaptan does that. And there's conivaptan that addresses both. Cool, I don't care. Just the drug class itself. It's not Farm. So vasopressin receptor agonists are an option. Loop diuretics, right, to help with that fluid overload. That can be helpful. And then, interesting enough, there's this tetracycline, demiclocycline, and this inhibits the effect of ADH. But if I'm inhibiting the effect of the inappropriate ADH being released, I inhibit the effect, what can that cause? If I go too low, we can induce the opposite, which is diabetes insipidus. Okay. when to refer these guys, I'm referring them at the beginning. You still have to understand the treatment, right? Even though maybe we're not managing these, because baptins you can only be on them for a short period of time because they cause they're very toxic to the liver. But again, we're managing them acutely if we need to with our hypertonic saline, and then we have baptins and diuretics and stuff for these patients. Okay, that's it for SIADH, inappropriate ADH that nobody invited to the party. And we'll have a break until I guess 2 after, and then we'll talk about diabetes.
Salt is good. No, we don't switch yet. We're here. Her mom.
She's like, this is the Air Force MVP. I'm pretty sure it's because I'm sitting 6 hours.
Oh,
Can't leave it. Yeah, that's true. So I painted like
that's fine. We're stuck here. They just look at each other like, who made the test? We don't know.
Next thing you know, things go crazy.
That's what I like.
What? Michael. I know. A couple of years. Yeah. Real baby. Yeah, I remember those pants.
Dude, I feel like shit back here.
I'm better.
I'm like trying to not just sniff, but also trying to yeah. I took a test with my tissue paper and shoved it up my nostrils. Yes, that's why I was very mad. I didn't feel like
I remember the first time we tried, I was dying, sweating.
there was multiple times where I was getting
Yesterday, I was inhaling.
I don't think they make sense. We're more that was the around that time, yeah, you can make that decision, a lot of these apps. A lot of people like just not force it, but like you're just kind of. I can't say I made a good decision you make sometimes. That's why, especially for me, I'm like, hey, this
And I really will. None of us would.
I would get back.
Do you wear PT clothes because of this hat?
Now we're gonna put cream on each other.
Okay. Wait, isn't Farmer Review?
It is.
Or we swap, yeah, okay.
Cream and topicals for us.
Oh, okay. Try this on. That's my favorite topical. Okay. Alright, so we're gonna get through this and then we're gonna do some cases and then I will hand you over to Major. So, shifting gears, no more inappropriate ADH, instead it's the opposite. So diabetes insipidus. What is diabetes insipidus? When we think of the Latin words, what is it? Diabetes. Yeah, and it's the word is insipidus is tasteless, right? So it's not tasty. Versus diabetes mellitus is sugary. Because they used to hit the urine, they used to taste that? Gross. I don't know. Apparently they did. So this is the unsweetened, your unsweetened tea version. Yeah. Okay, so thank goodness for modern lab testing. Okay, so diabetes insipidus is too little ADH, so you can't concentrate the urine, right? So this makes sense. The symptoms of this is very like straightforward, I think. You're gonna have a large amount of urine, and what is that urine gonna look like? Clear, dilute, clear urine. Okay, there's criteria. So this most recent version says 3 liters in 24 hours. Some resources will say like 2.5, but you have to, again, the key to this clinical diagnosis is excess urine. And we'll talk about the sodium level and just as we go. You have excess urine and polydipsia. What's that? Thirsty, right? So this is where it's pretty cool. So if I have not enough ADH and I'm peeing out all my fluids, what's happened to my serum osmolality? All my water's going out. It's concentrated, right? So my thirst center kicks in as I drink water. So I drink a bunch of water. So I am like trying to maintain my own homeostasis. Pretty cool, huh? All right. Okay, so there are, turns out, four types of diabetes insipidus. But I will tell you what's kind of cool about it is the name tells you where the problem is. So central, where's the abnormality? In the brain, right? Maybe something with the pituitary, the hypothalamus. So we have a secretion and synthesis problem. Nephrotic, where's the problem? Kidneys. So this is where we're going to see resistance. So that resistance hypofunction. It could also be like maybe a congenital disease or some kind of kidney nephrology problem that I'm not going to get into. Primary polydipsia, what does that tell you? Primary, I'm the problem. Maybe I have like an obsessive compulsive disorder, or I'm drinking a lot of water, or hazing, where they would make kids like drink a lot of water. You could get diabetes insipidus. And then gestational indicates where it's the problem. Right? Okay. So we're only focusing on 2 in this class, and that's central and nephrotic. Okay. So central synthesis issue versus kidney. We have plenty of hormone produced by the pituitary or posterior pituitary, but the kidneys, where it needs to happen, it's resistant, right? It can't do its job. Something's going on in the kidneys. So etiology, diving in a little bit again. Central, maybe like a surgery to the hypothalamus and pituitary gland. That makes sense, right? I'm messing around in there. Maybe I cause diabetes insipidus. Any kind of trauma or tumor, kind of CNS infection. So I'm interrupting how the hypothalamus, posterior pituitary work to release ADH. And then for nephrogenic, it's renal insensitivity, right? It's resistant. So a lot of times this is like polycystic kidney disease and things like that. Lithium. Why are people on lithium?
Crazy.
Bipolar disorder. This one causes that. And then wait, we know this new med, demiclocycline. Oh, I didn't say that. Demiclocycline. What's that? Remember, that's how we treated our patient. Remember, we had that patient with SIADH. They had lung cancer, and we're like, okay, we're gonna send you to the oncologist. So restrict fluids. You need to drink fluids, so we give them maybe this tetracycline to manage their SIADH while we can treat it, the underlying cause, right? So we cause the diabetes insipidus. Okay. You see, I'm oversimplifying the nephrology. And then the CNS etiologies kind of make sense. I think they're intuitive. How would a good medical history help determine if it's central or nephrogenic? A lot of times, right? We still need to rely on some labs and tests, but yeah, a good history could potentially help us here with our etiology. So, whether it's nephrogenic, central, if they present the exact same way. Polyuria, polydipsia, okay? Excess clear urine, okay? Over 3 liters in 24 hours. And they have excess, they're typically ice water, but they're drinking a lot, right? And that's your body's way of trying to maintain homeostasis. Now, what's bringing this patient in, right? Because do you see how they might not come in? Because they're like, I'm peeing a ton, but it's probably because I'm drinking a ton, right? So they might not put it together and come and see you. So you could potentially catch this in just like a well visit, or the minute, at least for me, the minute I have to pee and I get up at night and it interrupts my sleep, that's a problem. Because I like my sleep. You guys will get to enjoy sleep again in like a little while. 6 months, 8 months. But again, so if it interrupts your sleep, or if you with enuresis. Yeah, what is it? Yes, great. So if you're an adult and you not wet your bed and now you start eating, so you're going to come in, right? And we kind of use that information on how when we determine treatment, like who gets meds, who gets just hydration. So does that make sense? Signs and symptoms. This one's real like attitude. Okay. So let me just read this. I don't love reading sites, but majority of diabetes insipidus patients are able to maintain fluid balance by the continuous ingestion of large volumes of water, right? So they're maintaining their own homeostasis, or what is called compensatory homeostasis. So what that means is that when I check this person's sodium, you might intuitively think it's going to be they're going to be hypernatremic because it's the opposite, right? SIADH is hyponatremic, DI is hyper, but not necessarily. It can be normal a lot of the times, and that's because what they're doing. They're drinking, okay? But the minute what if I am put under for surgery or I'm in a coma, I lose my thirst center trigger. Then you can become hypernatremic. Maybe I'm going on a hike somewhere and I don't have enough water and I get dehydrated. Then I'm going to be more prone to be hypernatremic, okay? So again, the sodium level will vary, especially if they are conscious or not, okay? So if I want to ask a question like that, make it very clear. If I tell someone if they're conscious or not conscious, okay? All right. So time where this person comes in, they're peeing a lot, they're drinking a lot, they're waking up at night. Let's work them up. So ask them urine questions. Does it burn when you pee? Do you have blood in your urine? Do you have any back pain? What do I expect them? Is their urine going to be increased or decreased? Decreased, right? You guys got it. What labs? Think back to SIADH. What labs should we get for this patient? Urine, CMP, BMP. For those tests we just learned, those osmolality tests, right? Urine and serum osmolality. Okay, so if the underlying, like to have diabetes insipidus, I have to have what? Polydipsia and polyuria, right? Or what's my cutoff, right? They need to at least have 3 liters of urine per day. So how do I measure that? Yeah, for how long time? 24-hour urine. Yeah, we have a lot of 24-hour urine in ENDO. This is your first one. This one makes sense though. And then of course, I didn't catch it, but thirst intact. Is there thirst intact? That's an important thing to ask. So yes, you're gonna have increased urine, and then here's our lab. So we have this new lab, 24-hour urine, where they essentially pee and collect their urine for 24 hours, and you don't restrict their fluid intake. So it's gonna be a big old jug. We know this from already, urine osmolality for the concentration, a UA for specific gravity, rule out infection, diabetes, that's type of mellitus maybe. We like our sodium and our other electrolytes, serum osmolality. This time we can actually order vasopressin. It can be helpful, but it's not diagnostic. So you do all these labs, we get a good history, but the one like diagnostic test to confirm they have diabetes insipidus, central or nephrotic, is this fun test here. We'll get there. Labs and doing the labs. I tried to warn you. The labs are interesting. We'll get there. And then, oh look, a good history and physical exam will help differentiate between central or nephrogenic, right? Do they just have pituitary surgery, or do they have a known kidney disease? Okay, so here's our labs. 24-hour urine has to be high, right? That's just, and of course, doesn't have infection or any other kind of weird kidney stuff. Urine osmolality is low. Specific gravity is low, right? We have this dilute urine. Plasma osmolality can be elevated in both, or can be normal too, which is annoying. But again, we have that more concentrated plasma osmolality. CMP varies. Why? Remember, because if their thirst center is intact and they're drinking a lot of water, they might not be hypernatremic. Okay? And then vasopressin. So plasma vasopressin. If I have somebody who has central diabetes, so it's up here, so there's a problem that's up here, why would the vasopressin be low? Yeah, it's a synthesis secretion problem, right? Usually low. So it's not, so we can use this and a good history to point to central, but we still have to do that vasopressin stimulation test to totally confirm. Okay. Feel good? There's some overlap, which is nice. Okay, so here's our fun ENDO test of first of many. Okay, so vasopressin, it's in the name. What are we giving this person? ADH, right? We're giving them ADH and we're seeing what happens. So you and I are not doing this in our clinic. They are admitted and monitored, and they have to, their urine output, their osmolality, their sodium, everything is monitored for like anywhere from like 8 to 12 hours before. Then we give them ADH. We give them desmopressin. And we see what happens, okay? And we watch them over the next 12 hours. What do you think is going to happen if it is a central problem? We're going to see some changes, right? They're going to have a decreased thirst, decreased urine output, increased urine osmolality, right? We're fixing the problem, the secretion synthesis problem. With nephrogenic, we can give them all the ADH, and even all the ADH they want, or we think they need, and nothing will happen, right? Why? Problem is resistance, okay? Remember, the hypothalamus and pituitary are working fine. It's the kidney issue. You see how that's confirmatory? Kind of comes together. Here's a table. Yeah, if you like it. Again, I will tell you the life ranges, or I will tell you the normal in parentheses, or I will just tell you if it's hyperosmolar or hypoosmolar in the test description. Okay? The uric acid, I have that on here. It's like just sometimes you could have kidney stones and stuff, but I don't think imaging. So if you're thinking central, you can do an MRI. And people, so again, where's the powerhouse? Where's most of the action happening in the pituitary? Anterior, right? All those kind of hormones come out. But the posterior pituitary will show up as a bright spot. So for some reason they don't have that bright spot, it could indicate central. So you should order that while you're waiting for the vasopressin test. But not a real high yield sign test, or sorry, not a high yield flag per se, because it's kind of intuitive. Differential, you can write situational awareness, FYI on this guy. All right, treatment. So mild cases. Does this make sense? Just adequate fluid intake. How cool is that? See this little kid just drink your water. Maybe not from the sprinkler, but you stay hydrated, right? Because that's how they've been managed. All right. So if they're mildly symptomatic, they feel fine. They don't want to deal with the med. You could just be like, all right, just make sure you drink a lot of fluids. If you're sick, if you get like gastroenteritis, if you're really active, you just want to make sure you hydrate, right? You want to prevent dehydration. But some people will be okay with that. But if they're peeing at night, if they lose bladder control, then we're going to give them desmopressin acid. right? This make sense? We're giving them what they're missing, right? This is for central speaking. We're giving them what the synthesis and secretion problem is up here. We're giving them what they're missing. The sig for this is to give it twice a day. You would start just like at night. You would start at the lowest as possible. You give it to them at night, and then monitor electrolytes and all of that stuff. So this is something I would do really slow. You don't have to know. You give it to them at night or the sig or the doses. Just know the med, okay? I talked about patient education, all of that stuff. Hypernatremia is less likely, right? You know that if they're awake and they are conscious and have their thirst syndrome. Nephrogenic, really just treat the underlying cause. That's all I need you to know. This gets in the weeds a little bit because, so you think, you still have to maintain hydration, but when you think of a thiazide, so we could give, so they're peeing a lot already. When I'm going to give a patient a thiazide or a diuretic, what do I think is going to happen? They're going to pee. Wait, I'm giving someone who's already peeing a lot a diuretic. And the trick to why thiazides work is they just work more proximal in the nephron. Okay, so you give them a thiazide, and so it acts sooner than the distal collecting tubule, and it pulls some of that water back into the body. Not needed. What do I need you to know? Treat the underlying cause of the renal disease. Okay, this is all just. It's pretty cool when you read like the medicine piece of it, but not in the weeds for this class. Prognosis, they do pretty well, obviously, especially if it's post-op. So if you have post-op SIADH, post-op diabetes insipidus, they usually it's self-limiting. You're going to monitor them, and then they should get better on their own. And then that desmopressin, man, now you get to sleep. No more enuresis. You're happy, and then you would monitor. It's like a picture. This is helpful for your visual learners. This is just, I forgot to add this. Oh yeah, this is just the lab summary. Not to overwhelm you, but again, if you're like, don't feel like you have to memorize this, go back to homeostasis, right? Go back to that, and then intuitively you're like, oh yeah, urine osmolality is going to be high because the urine's concentrated in SIADH, okay? Same with like the vasopressin gel. What we talked about. All right, so we end each lecture with clinical correlations, and then we'll start the next lecture with check on learning questions. So I post these slides later. This is just your participation time. You guys participate so well. I know, on Friday. That was Friday afternoon after a test. This is Monday afternoon after a test. Sorry, guys. Okay, so we got this. All right, so help me out. We're going to see our first patient of the afternoon. We have Nathan Light. And he comes in, he's a 55-year-old male. He has a history of recent radiation treatment for metastatic small cell lung cancer. He's feeling nauseous and tired. Yeah, I'd probably be nauseous and tired too. What's going on in your head? We really only talked about two conditions, right? Yeah, so we kind of already know you're in ENDO lab. Okay, so, all right, so let's keep going. We get a little more history. He's gained about 5 pounds, but he does denies any like edema. He admits that you guys do a really good review of systems. Don't forget about your review of systems in Clin 4, okay? And you find out that his urine is darker than legally. Med history, he's on morphine and prednisone. And oxygen, what stands out about those meds? Anything? Not an SSRI. There's one thing on there. Morphine. Opioids. Opioids and ADH. Okay. So he's kind of technically has 2 hits. Vitals, we get a good history, we go to do our vitals, our physical exam. And are we okay with the vitals? Yeah, how old are you again? 55. Yeah, I'm okay with that. His lungs are actually clear, his heart, no murmur, thank goodness. And we have some initial labs to get a UA on him because he mentioned the dark urine. What is that specific gravity? High or low? High. What does that tell me? Concentrated. Really, can we just diagnose him with SIADH and call it good? No, right? Not yet. Not yet. All right. So what's the problem? It's not the diagnosis. What is this guy's problem? He's got a bunch. He's got cancer, right? What else? He doesn't feel good. He's got these opioids. Why did he come in? He didn't feel really good, right? He's nauseous. Okay. He's got weight gain, so maybe some fluid retention, and we have this elevated urine-specific gravity. Okay. What do we do now? Labs. In ENDO, it's always that. It's history, physical exam, maybe some initial labs, and then initial stuff, it's labs. After labs, it's rads, okay? So, what labs do you want to do? We got a UA, serum osmolality. The BMP or CMP for what's my favorite electrolyte? Sodium. And then we got a serum osmolality. Let's go ahead and do a urine osmolality too, right? Okay. Here we go. Well, it's bolded in blue, so it must be, it's not a blue baby, but it's bad. I don't know. So we have low sodium, low plasma osmolality, and high urine osmolality. Is this what you expect? Yeah. Okay, what is it? Perfect. What secondary to what? Right? Underlying cause. Small cell. And then those opiates probably aren't helping me. Okay. How do we treat this guy? This is that. Is he like, so it's probably chronic, right? Because it's been going on for over 2 days. He's alert, he's oriented. He's no cognition issues. So maybe we just do water restriction. We're going to educate him. We're going to make sure, we're going to send him to the nephrologist. We can consider some medications, but can't use that. Cancer meds, probably not a lot more meds probably than what I told you. But anyway, so we're going to restrict his water, send him to nephrology, okay? Because he's not he's not confused, irritable, he's not okay? Does that make sense? So we're going to restrict water because remember, he's low sodium is because of fluid overload. 3 days later, he comes back. And his wife says he's vomiting, and now he's disoriented to time and place, and he has a severe headache. Is this different? Would you call this more symptomatic, neurologic symptomatic? Okay, so, we have a sodium on him. Good job, guys. 123. It was 130. What's your assessment? Yeah, SIADH was worsening hyponatremia. So now how do you want to treat it? Yeah, hypertonic saline, but not too fast, right? This is chronic. Not too fast. We don't want to get that locked-in syndrome. Okay. We can consider Bactins. So once he's stable, we can consider Bactins or democlocycline, and nephrology will be on the phone. Okay. Look, you treated your first patient in ENDO, not once, twice. Okay. So Tinkerbell is a 40-year-old female, and she has 18 hours status post a transfenodal resection of an anterior pituitary adenoma. We'll talk about that surgery tomorrow, which is essentially, is adenoma cancerous usually or not? No, it's benign glandular tissue, right? That can secrete hormones. So she had this 18 hours ago, and now she's complaining that she can't sleep. She's super thirsty, and she's waking up to pee. She also reports she has never peed this much, right? What do we think? SIADH, DI? Okay, let's get vitals. Are we okay with these vitals? A little tacky, right? Yeah, okay, great. Just kidding. All right, so we do a physical exam and unremarkable for the most part. What do you want to do? Good history, yes, labs. Which labs? Same, but what else? So we have our BMP, our 24-hour urine, yes, we have our urine osmolality, our serum osmolality, our UA, and we can't even order a straight vasopressin. Okay, did all that because you were paying attention Monday afternoon and do all your labs, and this is what you get. What does this tell you? Oh, urine output's high. Urine osmolality is low. Urine, specific gravity shows this dilute urine, right? And it's high amount. So this one, because they're inpatient, it's not the 24-hour urine. It's just they're monitoring the urine output because she's inpatient. Okay, but the 24-hour urine is what I tell you. So that's what you do. Okay, what's this girl's problem? What's her not a diagnosis, but what are her problems? Polyuria, nocturia, polydipsia, and then her lab showed this, essentially confirmed the same thing, right? What does she have? DI. So what do you think it is? Central or nephrogenic? central, most likely, right? Because of why? Because you got that good history. How do we definitively figure this out? Vasopressin suppression test. Okay, so what do we expect to change? Does anything change or does it stay the same? It changes, right? Because it's a synthesis secretion problem, not a resistant problem in the kidneys, right? So we give her vasopressin, and we do it fast because she's already inpatient. And sure enough, we see a response, right? We're giving what the body is lacking. And we treat it. So, how do we treat it? What if it's mild? How can we treat this person? Just hydration, right? Just hydration, because she just had surgery. We know potentially the underlying cause, it could get better. So just hydration. But she's like, I need my sleep, so then what do you give her? Desmopressin, right? We're giving her what the body's missing, and we monitor. We do a little, it's twice a day, it would be at night, once a day. And 2 patients treated. Good job. Thank you for participating. See you tomorrow, but I think at like 1500. Sorry. Good luck with the farm.